Hola, my name is Laura Santos, and I had the opportunity to have Dr. Marble Flint as my mentor during this research. I wanted to pursue the topic of strategies implemented in speech-language services for bilingual adolescents as an inspiring speech-language pathologist who wants to work with bilingual individuals. My interest in the topic began when I asked myself, would clinical-based therapy and school-based therapy differ in the strategies that are implemented? For this topic, we're going to be looking at specifically at Spanish speakers. My mom works with bilingual students who are unable to speak their native language correctly. For those that aren't bilingual, you might not understand the mind of a bilingual individual, the constant code switching, and the struggles of someone not understanding you for various reasons. Many individuals struggle with their Spanish due to the lack of bilingual SLPs in the state of Kansas. Now you might wonder, why is this important? Adolescents are a neglected group within the speech-language pathology field due to the lack of research. This can negatively impact them by leading them to social, behavioral, and emotional distress. And it can also affect their literacy skills and academic success. Bilingual students often have issues with code switching, which is the practice of alternating between two languages or more in the same setting or at the same time. This can affect the child within the school parameters as well as at home, affecting the child and parent communication. My goal for this research was to find out what the strategies between clinical setting and school setting were, as well as allowing SLPs to benefit from learning about their colleagues' experience, comfortability, and ideas when working with bilingual individuals. To tackle the recollection of data, we decided to create a poster to attract participants. This way, we were able to conduct 3 interviews with 3 bilingual SLPs. 2 of them have had experience with both clinical and school setting. However, during the research, 2 of them worked at a school setting and 1 in a clinical setting. These interviews were conducted through a Zoom meeting for 30 minutes and included 10 total questions regarding different variables of interest, such as caseload, prior experience, parent and student satisfaction, as well as therapy outcomes when available. Questions included, how comfortable do you feel working with bilingual clients? What are some strategies that you have used in the past with bilingual adolescents that have proven to be successful? And many others. All of the data was looked at to find the differences between the 2 groups of SLPs. This is a table describing the participants. The participants' years as an SLP as well as in their current setting. The caseloads, the number of caseloads, as well as the age of their clients. As you can see, the participants with Spanish as first language feel more comfortable working with bilingual adolescents, and participant number 3, who has English as first language, feels more comfortable working with bilingual children and is now feeling more comfortable with bilingual adolescents. This might be due to the fact that participant number 3 has had 1 year of experience, and her caseload has been from less than 30 to 33 students per caseload. However, the rest of the participants have had many years of experience, and the range is from 40 to 60 students and clients per caseload. After completing the study, we came to the conclusion that both clinical and school-based therapy uses English and Spanish as a strategy. However, school-based therapy focuses more on the student's curriculum and social life within the school parameters. The SLP's primary goal is to tackle the student's language that is mostly used at school to ensure that the child is learning and continuing to have a social life without barriers. This helps the SLP. This kind of therapy gives access to English only when it's necessary. For example, an assessment might start in Spanish, and if the child is unable to comprehend, then it'll switch to English and vice versa. It helps the SLP understand which skill is available in which language. Now on the clinical side, using one language per session is used more often. This allows the SLP to tackle the language that is used at home and at school separately. In these settings, using both languages is very important. However, we found one thing that they all have in common. While completing the study, results for an unexpected question appeared. Because of some limitations, we found out that there's actually a lack of materials within the bilingual population in the speech-language field. All participants, no matter the setting, believed that new materials were clearly needed. Participant number 1 mentioned that this is an area that is lacking and wishes more materials were available for adolescents. Although there is a decent amount of evaluation instruments available, such as the Bilingual English-Spanish Assessment and the Arizona Test of Articulation, the Spanish Bilingual Edition, and many more, additional tools by the participants were suggested to improve the evaluation process. What the participants might enjoy seeing would be more testing materials to evaluate children of ages 3 to 7 and older, including pragmatic language tests being developed. As the participants continued talking, one of them mentioned the need for more screening tools, fluency tools, and language samples for students ages 7. Monolingual individuals are able to have their own test assessments for their development. Therefore, new norms for the bilingual population need to occur for them to have the same opportunity. Standardized assessments for the bilingual population need to occur. This helps the SLP and the bilingual individual. The lack of materials is causing SLPs to create their own assessments. For example, the outcome assessment and information set and the comprehensive assessment of spoken language 2 have been used to combined to create an informal testing for any scene delays or what the parent is concerned about. To resume, although new materials are needed, when comparing clinical and school-based therapy, they both use Spanish and English. However, they have one big difference. School-based therapy focuses on the student's curriculum and social life within the school parameters. Therapy on the clinical side focuses on the language outside of the curriculum. Because of the limited number of participants, we were unable to gather as much data as we wanted to. This clearly affects the results of the study. Not only this, but if the study were to be replicated, clarification of the word strategy would be helpful. Because of this, in our study, it led participants to talk more about the assessments that were needed rather than the strategies that have been used. These are the references I utilized during my presentation today. Now I'm open for questions. I believe speech-language pathologist focuses more on early intervention due to the fact that that's when we start noticing stuff. At first, when a child, for example, the age of 2, they're supposed to have a certain amount of words, and if the child is not reaching that point, then that's when they start noticing these things where they need to go to speech therapy. I think adolescents reach a point where they focus more on school setting rather than their actual speech. For example, with bilingual individuals, in an adolescent age, they already know English. They already understand what they're receiving in middle school. However, maybe at home, the school therapist doesn't have that access, so the language that they receive at home is not being helped with. I believe it's an issue because monolingual individuals have their own assessments, and I don't think SLPs should have to gather different assessment, one in Spanish and one in English, to complete an evaluation for a bilingual individual. I think an assessment created for bilingual individuals would be easier for both the individual and the SLP.